Welcome to the PA is in podcast, where we discuss entrepreneurship and evidence-based tools for running a small business. Today's conversation is for the PA who's wondering, is this really it? Because somewhere along the way, the role that once fit perfectly started feeling a little too small for who you're becoming. Roles, they are often static, and you, my friend, are dynamic. That mismatch often leaves clinicians feeling like their current job chafes in places that it didn't used to. Today, I'm joined by Beth Welch, a PA who started out in trauma and critical care and eventually made the leap into healthcare leadership and innovation at the executive level. Although we do talk about non-clinical pivots and what it really feels like to leave the bedside, we also unpack identity and what it's like to have influence without authority. And we dive into the shifts that have to happen as we go from clinician to executive leader. There are so many sneaky, sometimes hidden soft skills that PAs develop that make us uniquely capable of leadership, entrepreneurship, systems thinking, and navigating rooms where we technically don't have authority, but still shape the outcome anyway. We talk about burnout, the humanity in healthcare, and why careers are more jungle gym than ladder these days. We dive into how some of the most important work you'll ever do may not even have a job description yet. This conversation felt like a breath of fresh air, a coffee or a walk with a friend, and like someone finally was brave enough to say those important, quiet things out loud. Without further ado, here she is, Bethany Welch. There was a moment not that long ago where I realized something that made me really uncomfortable. I realized that clinicians are the best people to fix the way that we deliver care, but most providers have no idea how to run a business. We jump into entrepreneurship thinking, I just need a great idea, the perfect logo, maybe a website, no sales, no beta testing the market, not beginning your business with the end in mind. But then we wonder why it feels so hard, why our business is not growing, and why it's not paying us much or at all. Because no one taught us how to run a small business. Here's the reframe that changed everything for me. Your business is like a body. And if you don't know how to assess, diagnose, and treat it, it gets sick, needs resuscitation, and dies. Leadership, that's your business's brain. Marketing, its lungs. Sales are the heart. Cash flow is the circulation. And suddenly, everything clicks for clinicians because you already know how to do this. You just need to translate your clinical skills into business tools. And that's exactly what we do inside the Clinician Entrepreneur Collective. It's your small business clinical rotation, which makes me your business preceptor. Inside the Clinician Entrepreneur Collective, we take what you already know as a clinician, your incredible ideas and dreams, and turn those into a business that works, sells, scales, and actually pays you. And if you're ready to learn how to actually do that, we start our next cohort on July 1st. Head to tracybingaman.com/waitlist to join us. Beth, welcome to the show. Thank you so much for being here.
Thank you. Very, very happy to be here with you.
So tell us a little bit about you, what you do professionally, and also, if you're able, tell us about this passion project that you're working on.
Sure, of course. I'll start with the straightforward part, which is me and my background. So I am Bethany. I live in Philadelphia with my family, and I have been a PA for 15 years, which is kind of crazy to say. It feels like longer and shorter at the same time. But despite sort of starting my career in trauma and critical care as a practicing clinician, I am now a healthcare executive in the corporate healthcare world at a Fortune 500 healthcare company, doing a very different job than I thought I was going to do when I got out of PA school. And I'm excited to talk about more of what that looks like. But my passion project is really taking what I've learned from this meandering path of mine, understanding how it happened, why it happened, who I am as my identity changed throughout all of this, and really kind of helping other people see it, anticipate it, and be able to talk about it as they navigate it themselves.
Clinician to executive is not something that we hear a lot by way of non-clinical pivot. So this is not one of those pathways. It's like, Oh, yes. Then, of course, you went into, a company in the healthcare space and now you're an executive there. So tell me, how did you get from bedside to boardroom? What did that look like?
Just fair warning, like I said, meandering path. So we'll go through it. I've always wanted to be in healthcare. I was a lifeguard. I was an EMT. I went to PA school, became a PA. Went into critical care, trauma critical care, and that's what I was doing. And when I got out of school, that's what I thought I would be doing for the entire rest of my life. I ended up becoming the lead PA in that program just by default. I was the first one hired into it. It got much bigger. I became the lead because I was there the longest. By being the lead, I ended up spending a lot of time doing things like policy writing, doing a lot of like onboarding, building, and education for the incoming PAs and also the residents because it was an academic program. I found more and more that I liked that sort of structural systems work as much as I liked my clinical work. I ended up being on the APP advisory board at Jefferson Health in Philadelphia. And from there, I decided I really wanted to take a step and actually go into a more formal leadership role. So I left and became a clinical manager at the University of Pennsylvania. While I was at the University of Pennsylvania, I had the opportunity to work with the Pennovation team, which is the healthcare innovation arm of Penn Medicine, which was just really eye-opening for me. It was kind of like, sky's the limit. The answer is always yes to healthcare innovation. How can we make things better? What can we try? The answer is never no. Let's shoot for it. And so that sparked something in me as well. I ended up going back and getting my DMSC so that I could spend a little bit more time in that sort of administration and leadership space. Left Penn to become the director of clinical operations at Jefferson Health. So I went back to Jefferson. And there I was doing clinical operations for family and community medicine. And that's where I really got to do some innovative work around care delivery programs. So I got to work on the nation's first LGBT primary care program, where it was devoted population-based care program, a geriatrics at home program, a bridge program for patients with housing instability and substance use disorder on discharge from the hospital. And all of this time, I was still picking up hours in the ICU just because I couldn't let it go completely. I left academic healthcare and went into corporate medicine, corporate healthcare, where I am now. And that's when I finally let go of my clinical practice. So it's been about 2 years since I've set foot in a hospital for clinician reasons. And I miss it every day, but this is a very cool new adventure that I'm on, and very much not where I thought I was going to be when I got out of PA school 15 years ago.
And the thing that this is really striking me is I did an episode years ago on the fact that careers are now a jungle gym. It's not a ladder, right? So it's not like just the next rung, just the next rung, just the next rung on the ladder, but rather, hey, I jumped here and I swung over here and I climbed up this and I realized that this is and then I pivoted here and I really like that people are willing to say, hey, I switched from one organization to another, then I went back, right? That it was a very few doors are one way. Someone recently told me, like, in life, you can walk through a door, you can walk back through the door, you're leaving on good terms, you're not burning any bridges. There's always the opportunity to go back. And again, to go back to do something different, which is just a good reminder that, like, none of this is permanent, right? We can make a shift, we can try it.
Careers are long, they're very long. You can always come back. And the thing is when you come back, like you said, you're bringing something that you gained while you were gone too. So I think even in the systems themselves, they may not want to say it out loud, but I think, right, like more perspectives, a little bit more diverse way of thinking makes the pot richer. So you can always go back.
You sort of touched on this a little bit in your description, but I think so many of us identify as I am a PA. It's what I trained to be. It's who I am. I take care of patients. This is sort of, I am a PA, and this is sort of what I see myself doing. I see myself taking care of patients in some capacity from the very first day of my career to the very last day when I retire. And when we make these changes, we have to grapple with who we are if we aren't that bedside provider anymore. How was that experience for you as you made these changes?
I don't think I would have been able to answer this question in the moment as it was happening, right? It's like only upon reflection, looking back, as I've made those changes. But I think if I start by thinking about sort of like the PA identity, And in talking with other PAs, it's like you said, I think this is kind of a universal experience for us. Like, we are PAs, right? Like, we spend a lot of time devoting ourselves to this career, really intense education, like locked in a small classroom with like 15 other people that are like-minded and heading the same direction. So very much that is the identity, and you go out into the world and you're a PA. I think what happens is that for a lot of us, we do that very early in our career. Um, and it's wonderful. And we are just so happy to have a seat at the table, right? Like, this is what we worked so hard for. Like, I'm at table rounds, like I get to chime in. That's amazing. And I think what happens over time, right, is you continue to grow, but that role doesn't necessarily, right? Like, you as the PA on the multidisciplinary team rounding in the ICU, that itself inherently doesn't grow with you. You can grow it if you are intentional about it, but it's not just going to happen. And I think that that's where a lot of people in our position, especially as they get further into their careers, 5 years, 10 years, 15, all of a sudden it doesn't feel right? Like that, like I'm a PA identity just doesn't feel like it lines up exactly the way it did when you were 22, 23, getting out of PA school. And so that's what happened to me. And I had to really sit there and think about what that would mean, because if you're not a PA, then what are you? And what do you do with that? And for me, what happened is I literally had to answer that question because I left clinical practice. Like, I literally had to be like, oh, okay, well, the first year as a director that I am now, I introduced myself as a PA to everybody. And they're like, okay, like, cool. But it was important to me. Um, so I think what has to happen, right, is that what happens next? Like, who do you become? What do you do now? And that's another place where I think there's a unique space for us. Is that we are kind of the seers, right? Like, we are the ones who are in these health systems, and we are really just taking a lot of it in. Like, we are the ones who have the strong relationships with the patients. We're navigating the physicians, the families, the health systems. And a lot of times we don't have the authority in our positions to shape those systems, but we are seeing them. And so for me, I think a natural place when we reach that point where, like, I'm a PA doesn't feel like the extent of the identity. That's where a lot of us are just really well suited to fill in that space there, right? Is what do we see, and from our very capable and knowledgeable inside lens, what can we do to make things better?
And in my experience, it's very frustrating to see the gaps and to see the way that things are not going well. And also to be in a position where you don't have the power, you don't have the ability, you don't have the team to fix those things, because you're the one having the conversation with that patient at the bedside, right? I'm thinking of this one example of, I was on call for urology, and then I go in and I round the next morning, and there's this gentleman and his wife, and he came in overnight with maybe some hematuria, right? And they had this unbelievably frustrating experience where they were trying to get a hold of the office all day long, couldn't get through, couldn't get someone on the phone, couldn't get someone to call them back, right? Eventually called the answering service. The answering service says, go to the ER. This is maybe something that could have been dealt with in the office if and only if you had gotten the right person on the phone who got that person into the office to see the right nurse or the right provider. And they were like, hey, this was so frustrating. And I remember there's very few times that I've cried as a part of a patient encounter. And I was on call the night before, and I was so exhausted. And I was just like, yeah, that sounds terrible. Like, it sounds terrible to be at home panicking. This feels like a lot of blood. I'm having pain. I don't know what to do. I can't get them on the phone. We're scared. We're overwhelmed. We're not sure where to go. Yeah, that does sound, yes, like, it's entirely our fault that we don't have a system or a phone tree or, a triage ability, that we didn't get you what you needed, which was one of us on the phone, right? Which was you in the office, which was us dealing with this in the daylight, before you had to go to the emergency department. And I to the wife, I just said, like, I'm so sorry that happened. If that was my husband, if that was my father, if that was my uncle, I would have been really angry, and I would have really not liked this experience. And I was so tired, and I cried, which I, again, have never, very rarely done. And she was like, it's okay. Like, she's like comforting me. And I'm like, no, it's not okay. It's not a good, we didn't do a good job. We didn't do our job well. And I feel frustrated and angry on your behalf. And I'm also frustrated that, like, this was an admission that could have been prevented, and that you're here in the hospital, and that's a scary thing too.
So many failures, so many bad experiences all around, right? But like your post call, you'd want to go home. Like it is like, what are you going to do except say sorry in that moment? And I think in the beginning of, or maybe just for myself, but in the beginning of the career, there was a little bit of like, yeah, like I can be the one who like navigates this hard conversation, right? Like I'm the one who could take this call so that the rest of the team doesn't have to. And after a little while, it's like, well, why should anyone have to? Like, why can't we just make this a better experience? And for me, at least identity wise, I think that that's when I started to say, I am not a person who puts chest tubes in people in a trauma bay anymore. I started to say, I am a person who can make the experience better to increase the satisfaction of our healthcare providers, to make the clinical outcomes better. Lofty goals, but, tie my identity to that one.
And this is a completely different shift, right? It's like I was in the room and now I'm in the room talking about what happens in the room, right? So like by zooming out and by having this view of systems and operations and the things that you're impacting inside of a healthcare system, inside of the way that care is delivered, it's strange because you're both removed from that interaction, but also impacting so many of them. So it's like, by stepping back, you exponentially can impact more patients, which is weird and strange to think about. Like I walked away from the patients to make the patient's experience better.
The patient's experience and the provider's experience too, right? Because I think really, one depends on the other. The amount of nights working in the hospital where I would answer my pager so irritated, which is not fair. That's my job. I was there to answer the pager, but that's just like you're tired. You've been there for 3 16s in a row. Like it's the middle of the night. And then I have to go talk to somebody's family member, and like that's not a good experience for them either. No matter how much I tried to like bring it in. I'm sure that I seemed annoyed. I was annoyed. And then meanwhile, they're having the worst night of their lives. So like we need a better experience for the patients and for the clinicians, and not just the clinicians, but environmental services and the phone people and everybody.
Because at the end of the day, healthcare and the system that we have, broken and imperfect that it is people taking care of other people. And when we can improve the communication and make the system easier, it's not like no one's going to get sick and no one's going to try to die and no one's going to have a trauma and no one's going to get critically ill or hospitalized. It's that when those things happen, the system is set up so that the encounters can be potentially more positive.
And that is exactly where I've landed for my passion project. Is that Diagnosis Human is sort of this platform that I've launched, and really it came out of a lot of just my own sort of reflective writing about what I was experiencing. But it's about exactly that. It's about my belief that the humanity has really been sort of engineered out of healthcare and health systems. At the patient level and at the clinician level and at the environmental services and the front desk level, for a lot of reasons, for scale and efficiency, metrics, documentation, all of these things. But I believe if it was engineered out, it can be engineered back in. And so that's really what I like to write and talk about, is how do we take these problems in healthcare and really get to the root of them, which to me is a human problem. To me, every problem that exists in healthcare is because there's a humanity that has been engineered out of it. And so I believe that if we really examine it, we can work to put the humanity back in. And I do think that that'll help improve some of these healthcare problems. So I explore that a lot with my essay writing on my website, and then also with a book that I am working with an agent on for resubmission for publication now. So that is my passion project.
Is really the reason that if you ask someone who takes care of patients why they decided to go into medicine, 9 times out of 10, they say, because I wanted to help people, because I wanted to take care of people, right? Because I wanted to help people to feel better. Rarely do they say, I just love charting. The EMR just really gets me going, right? Like almost always about helping people to feel better. So talk to the clinician who's not in a position where they're doing operations or corporate executive healthcare, right? Where they're doing boots on the ground, taking care of patients day in and day out. What are some small things that that person can do to bring the humanity back into the interactions that they're having?
I think the very first thing is just to get a little unapologetic about understanding and hearing and talking and asking questions. I was actually on a panel for my alma mater, Lock Haven, recently for some undergrads, and I told them that if there's one thing that I think made me successful in my earlier career, is that I will sit down at any table and I am not afraid of joining any conversation. And it's with humility. I know that I don't know more than I do know, but you only learn by being in those rooms. So when you hear that there's an APP advisory board meeting, go to it. Like, hear what the people are talking about in that meeting. And if you don't hear them talking about the thing that you're seeing, talk about it. Talk about it there. But these forums do exist in most places, maybe not formally, but in my experience, there are a lot of people in healthcare that feel very passionately about making healthcare better. And so you just need to find that person and talk to them about it. I think that's the right place to start. Just, what are people noticing? What are you talking about? Where do those problems fit together? And how can you work together to solve them? And then just volunteer for every single like project, committee, anything you can get on, because that's how you get to know the people who have the ability to, one, tell you why it works that way, and two, that you can bounce ideas off of for why it could be better. And you just make the relationships and learn a bit more about the systems part, which is not what they teach us in PA school.
Yeah. We simply don't learn about the business of medicine, about the way that healthcare is delivered, about payers and contracts and all those things. I think just as a necessity of like, there's only so much you can learn in this time frame, and you're going to figure that out on the run. And we need to teach you how to, save patients and diagnose and treat things and look them up, right? And so those things just don't make the cut. And then you get out and you're sort of inside the system, looking at it from the inside, like, oh, is this how it's working? Right. And you're inside of it, like it's happening to you, it's happening around you. You are now sort of the cog in the wheel and you feel like that. You and I have talked offline about PAs specifically and how what we do in terms of training and education to get us to the point where we can practice medicine really uniquely and strongly positions us so that we can make some of these jungle gym nonlinear career moves where we're doing things where we're sort of seeing those opportunities and filling them, whether it's entrepreneurship or that executive space. Why do you think that we're so well poised to do that?
Yeah, so I agree completely, right? Like, something can't get taught in PA school, and they're probably like, half of you won't care to learn this anyway, so we won't talk about it. But they do give us the skills to navigate these spaces for sure. They just don't explicitly name it that way. I do think it would be helpful for us to start naming it that way so that people know how to deploy those skills in later career. But to me, there's three big things. The first one is the systems thinking, right? That's diagnosis. That's diagnosis medicine, right? The medical model of training trains us to think in systems. It trains us to think in like three steps and like three outcomes, three interventions at once, right? Like, this impacts this, which also has this. And you have to think about all these things in a system. There is no silo. So I think that we very quickly learn how to think that way. And while we don't explicitly say it, you can apply that lens to virtually anything that you come across, whether it's in your personal life or in your work life. This sort of zoomed out understanding of the way things fit together, and how kind of like pulling on this one thing here is going to impact this other thing over here. The second one is the our rotations. So, right, we go on these rotations every 5, 6 weeks, 8 weeks, whatever your program is. We're thrown into an entirely new city, sometimes new preceptors, new specialty, renting an apartment from somebody who recommended it to you because they did it the last 6 weeks. And we get very comfortable with being uncomfortable, right? Like we get very comfortable with showing up in a place where we walk in the front door and we don't know where the department is that we're going to. We're not sure what the person looks like. We're just going to go ask questions. We're used to getting, pimped in the rotations about all of the different clinical things that we should be remembering, and having to say I don't know, or making a guess and then wishing you hadn't made a guess. But we are just very good at being in these spaces where we don't know anything and we're very uncomfortable. And the only way you succeed is by just being okay with being uncomfortable, and being okay with being wrong, and being okay with looking dumb sometimes. Because the thing is the next time you won't sound dumb because you know the answer. So I think that system thinking combined with that discomfort tolerance is sort of the pillar. I've thought about this a lot too since you and I talked about this too, because I was like, well, that's med school too. So like why would this be different for physicians than us? And I think the real missing piece when we talked about this last time is ego. Honestly, I think that we come into practice as dependent clinicians, right? Like we come into practice always knowing that we will not be the attending, right? We come into practice with humility as a part of a multidisciplinary care team, a vital part, an instrumental part in the success of health systems in the United States. But right, we come out knowing that we fit into a broader picture. And I think that that's a little bit unique to the PA space, because what that is, if you put the soft skill name on it, is influence without authority. Right. So a lot of people get out into these big positions and they have literal authority. They are in positions of oversight and authority where they can say go or do, and those things just happen. And the PA space, for us to impact the outcomes for patients, treatment decisions with the physicians, interactions with families, we have to do it through influence. And so we get very good at understanding how to connect with people very quickly, how to appeal to the things that they care about, and how to really sort of get coalition around, for example, a treatment plan on multidisciplinary rounds in the ICU, when you're not the one who actually gets to say, like, yes, for sure, this is what we're doing. And so I think that's a unique thing that we build as PAs, that I think is probably unique compared to most other professional, like higher education careers, is really the baked in influence without authority. And that's the one that I really think the PA school should do a better job of naming explicitly, because it's a lot more helpful when you know that's what it is and you can choose when you need to use it.
There's so many, I can think of so many examples of preceptors, sort of saying like, yeah, and when they come in and think this, I say or do this, right? And they're demonstrating that. They're telling you, this is what I do for this person. And I work with surgeons for the last almost 15 years. I'm not sure if you've ever met surgeons, but the good ideas come from them and the bad ideas come from anyone who's not them, right? So and I just so funny. I just had this conversation with someone where I was like, I don't really think I can put this on a CV, but maybe I can name it now that we've had this conversation. But I was incredible when I was in the OR, with making a suggestion, but making it seem like it was the surgeon's idea, right? Like, what if we did this? And I'm not like, we're doing that, right? Because I'm not captaining the ship. Like, I'm like the first mate. I'm there and I'm helping and I'm doing what you need me to do. But like, I wonder what would happen if we looked over there or did this or got the mesh or tried this. And then it would be a couple minutes. There's always a lag, right? That goes in the person's mind. They think about it. They think, yeah, actually, I wonder what would happen if we looked under there or retracted differently or got the mesh or tried the thing. And then they would say it. And the nurse would be like, yeah, because we all want what's best for the patient, right? So if it has to be a little bit of your idea because I suggested it, amazing, right?
Yes, yeah, 100%. And you should put that on your CV because it is a real skill. It's influence, and it's a really important skill. I think in any, whether it's, executive leadership or entrepreneurship, right? Like probably one of the single greatest skills for PAs to be effective that sets us up for whatever we want to do with our careers.
And owning that. And also sort of taking a look at yourself and like, let's say you find a non-clinical position. Let's say you're thinking about going to do something and the resume for that looks different than a clinical resume, right? Like those skills. So sort of thinking about the way that you interact with people, the things that you're known for, they call you when they can't get someone out of the hospital and you talk them into leaving, right? They really need to leave. They're better, but they don't realize they're better and they would like to stay. So you're like the closer, right? And so that's a skill set, right? That is something that you're like, listen, I'm really good with people who are resistant and, don't want to do the thing and getting them on board. Well, that sounds a lot like selling to someone who never didn't want to buy your product, right? Like that sounds a lot like, getting an executive on your team who is completely anti the project that you're pitching, seeing that project has value, right? So think about those things that you're sort of known for and good at and the things that you do well clinically, and think about, take away the medicine aspect of it and think about what does that mean that I'm good at and how can that translate into business speak? How can that, translate into startup speak? How can that translate into sales or MSL speak? Because those skills are absolutely transferable. They're transferable specialty to specialty, which we just sort of accepted and know, but they're also transferable from the bedside to very many different rooms.
100%. And if all the examples that you have to share, like say you're in an interview and they're like, tell me about a time that you were persuasive. If your only opportunity to like explain that was a clinical experience, use it. Like it's not less because it's not business. It's, if anything, it's harder. The stakes are higher. So yeah, 100%.
So tell people where they can go to learn more, to follow along, to read some of these incredible essays, and just sort of tap into this. How can we restore the humanity in modern healthcare discussion and movement that you're creating?
Sure. Please tap in because I am one person who has like this amount of exposure and knowledge about the healthcare system. I'm learning. And I love hearing from other people, but my website is bethanywelch.com, BETHANYWELCH.com. And I have a little bit just like of a bio and sort of where I'm going to be next on there, as well as links to my essays. I've got a contact form on there, so please feel free to reach out to me, whether it's just to chat about something that you heard me and Tracy talk about today, or another idea that's been kicking around in your head. And then hopefully as my book reaches the next stages, I can keep everybody posted on that on my website as well. And of course, I'm on LinkedIn.
Absolutely. And we talked a couple of weeks ago, and in that time, you sat down and wrote a piece and sent it to me to sort of pre-read before it hit the shelves of the internet. And I was blown away. And I think probably in the email to you, I was like, you just sat down and wrote this? Like you just wrote it? It was so good. So, if you're looking for a reminder of what is good and, the things that we need to be reminded of as we're sort of slogging away and occasionally very frustrated with the healthcare system, definitely check the website out, check out some of those articles and essays, because we need more of that in our lives, that positivity and that reminder. So thank you for doing that work. It's very, very important.
Absolutely. If there's one thing that people take away from my website, I hope it's permission. Like I hope I am giving you permission to be a human in this space that does not always value humanity.
Thank you so much for sharing your time with us. We really appreciate it.
Thanks, Tracy. I enjoyed it.
What an important reminder that your career is allowed to evolve, that you are allowed to evolve, and that you're not failing because the version of success that you wanted at 24 looks a lot different from at 34 and at 44. And that the skills that you've built as a PA, that adaptability, those systems thinking, the processes, the influence without authority, your own emotional intelligence, and the ability to navigate uncertainty, those skills matter in far more rooms than just your patient's exam room. A huge thank you to Beth for such an honest and deeply thoughtful conversation. You can learn more about Beth and her work on her website and through her platform, Diagnosis Human. If this episode resonated with you, could you do me a favor and send it to another clinician who's been wondering if there might be more possibilities available to them than they originally imagined? Thank you so much for tuning in to another episode. That's all for today. This PA is out.